Back in my sophomore year, at the beginning of the pandemic, in Miss Peck's Intro to Medical Sciences class, I watched a TED Talk, which was incredible, and it was about essentially gender medicine. A lot of it had to do with themes of my current project that I'm presenting today. That TED Talk really set forth so many series of motions, so many late nights, spent researching, women in medicine, patients as well as physicians, and it really gave me a broad perspective into what gender medicine really is, which allowed me later on, 2 years later on to be exact, to really focus that into what my thesis is. And second of all, my personal experience, once I found some of these themes in gender medicine, I started to notice them in my daily life, identifying as a woman. And that really reinforced my passion for the project because I realized this isn't something we read about in a textbook that happened 3 years ago. This is something that's very relevant to our contemporary medicine age and something that's obviously very nuanced and perfect for a GSI thesis. So a couple clarifications before we really get in. This project is on gender medicine. Now, what is gender medicine? Gender medicine is the acknowledgement and essentially the fourth work that's put forward when we acknowledge that there are inherent differences between men and women when it comes to medicine. So that means physiological differences beyond just the reproductive system. And this is a really important acknowledgement when it comes to female health because otherwise women are just assumed to be men and male anatomy and male physiology, just with a different reproductive system and different organs. And that, as we'll see later on, has been a really detrimental assumption. And kind of going off the gender medicine cisgendered idea, there are a lot of complications that happen with medicine between physicians and patients. And unfortunately, that's not limited to women, that's not limited to any gender identity, let alone intersectional identity. So just as a disclaimer, for brevity, today I'll be speaking on behalf of cisgendered women and their experience with medicine, but that is not by any means the full parameters of this topic. Transitioning, sexual dimorphism is a topic and a term that comes up a couple times in my presentation. It comes up in my thesis as well, and I figured I would just define it just to be extremely clear. Sexual dimorphism is a phenomenon that's seen across 98% of the biological species outside of the human race. And it is the idea that there are inherent differences between the male and the female species of a species, if that makes sense, beyond reproductive effect. So very similar to gender medicine is just with the focus of the human species. But sexual dimorphism focuses on the idea that there are inherent differences that are not related to reproductive reasons. Now, my problem statement is that not only has women's health historically been neglected, but now the lack of adequate research into gender medicine has become detrimental to women. Just kind of like an all-encompassing issue of what I've been researching throughout this process. And a couple guiding questions that I use to really guide my research and really attack the problem of gender medicine, like I said as I focused in, is that I did a case study between the US and between Sierra Leone. Sierra Leone is a West African country in Africa. Sierra Leone has a very different culture, especially a medical culture, than the US does. And this provides an excellent comparison country to look at if gender medicine really is an issue for all medical practices, for all women of all identities, and for cultures, and for nationalities of where they're from, i.e. Sierra Leone or the US. But it also brings up the idea that if this seems like it's just solely a US issue, is gender medicine then a luxury, or is it a necessity in medicine? And that's where I got my title from, is that if we can see these patterns throughout different nations, throughout different medical institutions, then it's clear that this is an issue with women in medicine, not an issue with US women specifically that have that luxury. Finally, where I kind of got into my solutions later on in my presentation is what can be done to remediate this damage, assuming that gender medicine is a universal issue and not just a US luxury of something to further medicine. For my conceptual framework, I figured out that gender medicine is not just a sole issue of, oh, this is one thing that happened in an isolated incident. For the US specifically, it's an issue that started 80 years ago, and since then it's been a snowball effect where one thing is built upon another. The lack of research early on has led to the assumptions, which have led to more inadequate care, and it's just built on itself since then. For Sierra Leone, it's been a cultural difference. So, going back about 250 years, the culture made certain implications that made certain assumptions about women, and that's been perpetuated since then. So in both countries, in both Sierra Leone and the US, this has been a perpetuating effect that hasn't been an isolated event, you could say. Yeah, it's been a fairly new discussion for the US, 80 years compared to 250. And that definitely has an effect on it, but that also comes from the origin of gender medicine in both countries, respectively. In Sierra Leone, there's a lot more cultural impact than there is in the US, so that definitely has an effect there. And as for part of my final project that I did, when I did my interviews, I chose 4 of my interviews specifically. I left out the rest for brevity and for relevance. But my interviews were chosen initially specifically with that individualized medical perspective in mind, to really get a full assessment of this issue internationally, locally, and every topic in between. That being said, like I said, in the case of brevity, I chose 4 main issues to focus on to really show the expansiveness of gender medicine, and that is pain management when it comes to men and women, pharmaceutical drugs and how those are metabolized and processed, heart disease, as it's been known, and the physician-patient interaction, which is obviously a lot more personal, doctor to doctor, physician to physician. But I found that to be a relevant note as far as gender medicine goes, because we all deal with medical professionals. A couple perspective points to put this into a frame just to understand. Heart disease has been known historically as a man's disease that is detrimental and harmful and deadly for women, which is interesting to me personally because everyone has a heart in this room, everyone has a cardiovascular system, and yet even that idea is gendered. Like I said, putting this into a framework, into a perspective, in 2004 in the US, 7.3 women died over the age of 60 of heart disease, and 6.2 men died, which means over 1 million more women over the course of just that year, over the age of 60, have died of heart disease. Which, to me, frames that a little bit differently. Is it a men's disease? Is it a women's disease? Is there any gendered issue here, or is it just something that should be acknowledged overall? Coming to autoimmune conditions, 3/4 of all patients that are diagnosed with autoimmune conditions are women, and yet most of the testing is done on men. Which, again, kind of strikes me as strange when everyone has an autoimmune system, no matter the differences that there are, and yet even that is a gendered issue. Speaking on autoimmune conditions for a bit, it was found that men and women do have grave differences in their autoimmune systems. Women are known to have more adjustable immune systems, which is thought to also contribute to the longer life expectancy for women globally. And on chronic pain, women are known to be more likely to be diagnosed with a chronic pain condition than men are. And this goes back to the point on sexual dimorphism. There are inherent differences in how male and female brains perceive pain. And this can further contribute to the chronic pain issue that there's not really an explanation for this pain. There's no external force that's labeled as chronic pain, and women are far more likely to have that label put on their pain that they're experiencing because of the differences of hormones in their brain. To bring a specific point from metabolizing pharmaceutical drugs, women are 40% more likely to have a sleep disorder than men, which, roughly assuming, makes them 40% more likely to take any sort of sleep-inducing medication or melatonin to help them get to sleep. Ambien is one of those drugs. It is a pharmaceutical drug that was approved back in the 1900s, and it's been used widespread for men and women alike. It was only tested on men and male cells, though. So they found that women metabolize Ambien 60% slower than men do, which comes to be a problem when, like I said, women are 40% more likely to take a drug such as Ambien to fall asleep. And what happens when it's 8 or 9 at night, they take this drug, maybe it kicks in a little bit later because they're just used to that, women do metabolize it slower, but then 8 hours later, 9 hours later, they get in the car to go to work the next day. And because it metabolizes 60% slower and the drugs haven't been tested on women, they're getting in a car and driving to work that next morning, still on Ambien. And I wonder how many car accidents have been caused and how many deaths have been caused because there wasn't equitable research done, specifically with Ambien and with many other drugs, that then caused this detrimental effect years later. Getting into my research articles and some of my sources, this was the TED Talk that I watched actually 2 years ago, almost to the day, in Ms. Peck's class by Dr. Alison McGregor. She is an emergency medicine doctor, and she spoke, like I said in the beginning of my presentation, she spoke a lot to gender medicine as a whole, the full range and the full spectrum of every effect that it's had, everywhere that it's come from. And she brought up a phenomenon that used to circulate around with women's health called bikini medicine. And as I mentioned earlier, the argument with sexual dimorphism is that there are inherent differences between men and women beyond reproductive organs, beyond reproductive systems, in heart conditions, in vascularity, in brain chemistry. And bikini medicine is the exact opposite of that. Bikini medicine is, men and women are the same, except for the reproductive organs, i.e. the things that are covered by a bikini. And that entire premise of women's medicine has led to this downfall of female medicine as a whole. It's led to the inadequate assumptions, and it's led to, ultimately, an inequitable treatment for women as medical patients. Dr. McGregor also talked on sex-determining chromosomes, To keep it brief, for those that aren't the most familiar with biology jargon, sex-determining chromosomes were believed to only be limited to the 23rd pair of chromosomes, right? XXXY. And once that idea was disproven, that there are actually sex-determining chromosomes in every single cell of our bodies, which means that a hair follicle, a blood cell, a cell within your intestinal wall, all has the DNA that also determines what 23rd pair of chromosomes that person has, which means there is evidence for sexual dimorphism. There is evidence that every single cell between a man and between a woman's body is inherently different, and not just in the chromosomal way. And that's a major, major argument in favor for the gender medicine issue, and further arguing that there needs to be adequate research into these sex-determining chromosomes in every single body system that there is. So this table is representative of 10 drugs that were pulled in 2000 by the FDA, 8 of which for their adverse effects on women, and 6 of those 8 for their adverse effects on women's heart conditions and women's heart health. A couple of things are poignant to me here. First of all, I can mention a lot of things. For one, that 2 of these drugs were appetite suppressants, which just shows the cultural impact that there is on a woman to maintain her cultural image or her social image. But more than that, it's interesting to me that there was even one drug that was a cardiovascular drug that was prescribed to women, and yet was only tested on men, and furthermore caused a completely different heart issue of a lowered heart rate that was known to even be fatal sometimes. So again, everyone in this room has gone through COVID. We're still kind of coming out of that. And we know from the vaccine that it's incredibly hard to get things passed through the FDA. All 10 of these drugs were already passed 20, 30, 40 years ago before they were pulled in 2000. So for them to be pulled, there is an incredible amount of evidence, you could say, that is causing for that pull for these drugs. And not to mention, in the first place, for these to get passed, they went through extensive training just only on male cells. So I thought that put a great perspective on things, that all 10 of these were pulled, and 80% of them were for their adverse effects on women. I would say over the summer into the school year, I read a book called Pain and Prejudice: How the Medical System Ignores Women and What We Can Do About It. And the author, Gabrielle Jackson, she'd been diagnosed later on in life with endometriosis, an incredibly painful chronic pain disease for women or for people with uteruses. And she spoke a lot of her personal accounts. Again, a fantastic book that she wrote on the full perspective of gender medicine and a really wide spectrum on everything that it affects as well. She brought up an idea of medical privilege. And I hadn't really thought about this before, really, in my gender medicine thesis or my project thus far. But when she brought it up, it was something that I couldn't ignore. And it kind of goes along with the preface that I gave before my presentation, that this is an issue that affects people with many different gender identities, people with many different cultural identities and intersectionality within that. But there is a sense of medical privilege when it comes to physicians and patients interacting with one another. And that comes with, more affluent women have the luxury to doctor shop, and they're seen as such. They're seen as, a patient that's just going to one of another doctors. People of color or women of color are seen as trying to get out of work, unfortunately, when they go to seek help for their pain or for their medical needs. And I think it really puts into perspective how deep of an issue it is that not all women are even lumped together in, women are just going to, blow something out of the water and say that it's so much bigger than it is. It runs so much deeper than that, because all of these secondary assumptions are made based on women, based on their intersectionality of identity, and not just for a female identity. So it does go much further than that, but it's unfortunate. And often when there are interactions between physicians and patients, there is a need in the medical community to put something in a box. And as lovely as that is for all types of medicine, when something doesn't get put in a box, because human bodies are different and women are different from men, and without that adequate research, nothing is going to be known, there becomes a default to blame women for their pain. It must be in your head. You must be imagining it. If there's not, a bone breaking through the skin and you're not in abject pain from that, there must be some other reason why, and it must be your fault, because certainly nothing could be wrong with medicine. And that also leads to, like I said, the snowball effect. It leads to a super detrimental downfall, because then we see decreased trust from women in their physicians. We see decreased likelihood in seeking out treatment. And of course, decreased likelihood now in the 21st century. We are doing some remedial research into how women process drugs, how women respond to medical treatments that were previously only tested on men. And we see a much larger interest from men participating in these medical trials for comparison. But we see, only so many women wanting to participate, because there's only so much morale that's left once they've been not believed from so many of their physicians. And to my final point here, hysteria has an interesting of a backstory, to just give a bit of a background for a minute. Hysteria comes from a root word, hysterectomy, hyster meaning womb. Hysteria was thought to be an illness of the womb, an illness of the cisgendered woman inherently. And when this came about, we saw it kind of fading in the 1960s, 1970s. And once that started going away, we saw a new word, somatization, being a little bit more sensitive to everything that was happening. And Jackson makes a point in Pain and Prejudice to, pose a question, is hysteria not just disguised now in somatization? Is somatization not just a new age perspective on hysteria, still blaming women for what they're experiencing and still invalidating that for a way? So, that's a question I pose to you. There was a pain study done in 2009 on the language that women and men use to describe their pain. And ironically, the organization is also called PAIN, which I thought was pretty nifty. But women are found to use far more graphic language and focus a lot more on their sensory experiences when it comes to describing the pain that they've been through. They use a lot of analogies, like, it feels like I'm being hit by a car, when they're super exhausted with fatigue or with malaise. They use a lot more connection with their physician, granted that they're comfortable, to really express what they're going through. Men are more likely to use fewer words, they're more likely to focus on the main events, and interestingly enough, focus on the emotions that they feel when they're going through pain. They say that sometimes in the study there were 2 men that noted that sometimes psychological or emotional pain is far worse than physical pain. And while interesting, the overarching findings here in the conclusion is that the graphic language and the focus on the senses and the desperate analogies like being hit by a car or being hit by a bus, those create a very vivid image for physicians. And unfortunately, men and women alike in the medical field and as physicians both interpret this to be quite an exaggeration of what they're experiencing. And that's where we also see a lot of the downfall from gender medicine, is that it doesn't matter if there's a female or a male physician treating women. Unfortunately, the bias is across the board. For my methodology, obviously using the case study of Sierra Leone to compare and contrast was super integral for me. Like I said, they're very different when it comes to cultural impact and when it comes to history, and this really shows that no matter what, gender medicine can end up being the same. I also used a variety of academic resources that were available, and I vetted my interviews to be largely credible people that could speak to the questions I was asking, even as specific and really in a niche that they are. And then I looked for a couple of personal accounts. With a couple of my interviews, I did ask them as physicians, what have they experienced with their patients? What have they known themselves to maybe cross the line a little bit over on a couple times? And I got some really interesting responses, so we'll get to that when we get there. My first interview was with Dr. Reza Asabi. I met Dr. Asabi when I was at a medical conference in California, and he was speaking on behalf of his road and his path to going through medical school. He's a graduate of UCLA and of Vanderbilt for his medical degree, and now he's an emergency room doctor. He talked a lot about, interestingly enough, similar to the Pain and Prejudice book that I read, the intersection of identities and how deeply rooted the issue of gender medicine is. And as a male physician, he acknowledged that this was an issue that he's definitely seen amongst his colleagues and even within himself. And I asked him, as a newer doctor, he's been practicing for about 6 years now, what has he done to remediate this issue personally with his patients? What has he done to really break through that stigma that kind of comes around a female patient with a male doctor? And he said, keeping his vigilance, keeping himself to such a high standard of, I have to make sure that whatever the worst case scenario is with this patient, that is covered. And once that is covered, then I can really take a step back and reflect with myself and make sure that I'm treating this patient with, nothing more than my best foot forward. And I really appreciate his honesty with that we're all human. He mentioned he grew up in the city of LA, and that a lot of these assumptions, a lot of these biases are ingrained in people from an early age, and that's not individual to physicians, it's not individual to any person. And he mentioned that it's overcoming these that is really the difference between a biased physician and a physician that really has something to help with a patient. And he said that when it comes to treating a patient, you have to make sure that your do no harm is not just a surgeon in surgery making sure they're cutting something they shouldn't. It really is interacting with your patient on a daily basis and really stripping away the privilege that you've had from whatever background you've come from, and taking a step into who this person is, where their background has come from, what emotional foot forward they're going to be putting into this experience with their physician and how that's being affected by the physician's response. He also mentioned something that he took from a couple of his mentors called the 5-minute rule. And I like this a lot because he says that some of the best physicians that he's ever known, were, if they imagined themselves to be just 5 minutes away from being in the same position as their patient, they were often a lot more likely at times to be able to help them with the full variety of their ability. Because when it comes to physicians and medical personnel, we find a lot that it's not ability that affects their treatment of the patients. It comes to the direct patient to physician contact and how they're really approaching the issue before they're even treating the patient. And I like this quote here that he said, if this person were a white cisgendered guy, how would I treat them? Just to put that into perspective of, are there certain cultural, biases that I have? Are there certain gender biases that I have of, because she's a woman, she's making this up? Would you think the same thing of a white cisgendered man? Just a quick quote that I liked from him. He says that, a lot of his mentors did practice the 5-minute rule, and and a lot of it is humility. And I found that word come up a lot actually in my interviews. There is a very well-known prestige around medicine and anyone that practices it. And to strip away that pride for a second and say, I don't know what's happening. I don't know what's happening with you as a patient. I don't know the full, parameters of what you're experiencing, is the first step towards a really strong patient-physician relationship and a really strong relationship to foster in a patient's treatment plan. And so I thought that, the word humility that he used was fantastic, as well as saying, again, stripping away the pride and saying, I'm 5 minutes away from being in your same position. I will do my best to help you. Let's figure this out. My next interview was with Dr. Babak Kalantari. Dr. Kalantari fully agreed to my quotes being used from him and my notes from our interview, but he preferred that his picture not be posted, so I wanted to respect that. Dr. Kalantari is a diagnostic radiologist, and he gave me a little bit of a different perspective as someone that's still very much ingrained in the medical field, but someone that doesn't have a lot of day-to-day patient interaction. I remember him saying that they're mostly an outsourced field, that a lot of other medical personnel refer to them for their medical needs, but not directly to patients. And so he said that he hadn't seen a lot of that gender bias because an X-ray is an X-ray is an X-ray. Someone's rib cage is just the same as anything else. And yet when I dug a little deeper, we found that X-rays aren't all the same. There is a difference, even if you're not speaking with someone and questioning if their experiences that they're telling you are entirely valid. There is a difference in medicine with saying this person's anatomy, this person's physiology, I'm interpreting to be different because I know what their identity is versus saying everything's all the same. And he even mentioned a time when he was in medical school. And unfortunately enough, I think they were first or second year medical students, and they had up 2 X-rays in a lecture, in a class. And before the lecture had even started or even a question to be prompted, someone wondered why there were tumors, massive tumors in this patient's chest cavity. And it turned out that they weren't tumors. It was just an X-ray of a woman, and her breasts looked like tumors. And first-year medical students that had been all the way through college thought that they were something wrong with the body because they had only seen male X-rays of the chest. And I thought that really kind of gave me insight. When initially Dr. Kalantari said, oh no, I don't really see that, I don't know, I don't work with patients a lot. Gender medicine goes a lot deeper than that. It goes a lot deeper than how you treat a woman face to face. It goes so deep into interpreting scans, into interpreting medical treatments, medical procedures, etc. One of my first interviews was with Dr. Karen Asher. We know Dr. Karen Asher very well in our family. It's kind of a family friend. But her and her husband, Tom, they're both doctors of osteopathic medicine, which is the same thing as an MD, medical doctorate degree, just 400 hours of extra training into a more holistic view of medicine. And I found that pertinent to know when it comes to gender medicine because it seems like she really had an excellent grasp on that from her degree. Both the Ashers, they're both doctors, but they founded an organization called the WAM over in Sierra Leone. And they work with 35 clinics and 15 hospitals over there. A lot with OB. This is Dr. Asher holding a newborn in the obstetrics and gynecology unit. And she spoke a lot to the cultural impact on gender medicine that there is in Sierra Leone. They said over there that there's a much different perspective when it comes to pain. And just to put that into, what does that mean? Do they interpret pain differently? How does that work? They don't cry at all, ever. And they get very uncomfortable when anybody cries for an emotional reason, for a pain reason. And even Dr. Asher divulged with me, she's the first one to cry in a sad movie. And so, there were a couple moments over there where someone would be crying and they had absolutely no idea how to react. And that's with an emotional response, let alone getting an amputation. I also quoted her as saying that even with an amputation, all that they have there is Tylenol and Motrin. That is it. There is no other pain medication. There's minor local anesthesia, and occasionally they'll use general anesthesia to be put under for any kind of like stomach surgery. But it is an incredible tolerance that the men and women have there. Speaking on men and women, there wasn't much difference between how they interpreted pain and how they were expected to express their pain. Men were just as likely as women, and women just as likely as men, to conceal their pain, to shut down, to be quiet. And that's what Dr. Asher said often happened when you knew that they were in the most pain, is they got very quiet and they got very still. And you had to push further, like, hey, are you in pain right now? And even then, they would just shake their head and stay very still. And it took a little bit of pushing for both men and women alike, no matter the surgery, no matter the circumstances, to really get an answer of, yeah, I'm in some pain. Because they would never say, hey, doc, can you help me out? I'm really experiencing some pain. I'd like that epidural to go through pregnancy and to go through birth right now. There was none of that. And I find that interesting because on one hand, you have the US, and you have kind of an invalidation or a questioning of women experience pain, like, oh, she says she has a headache, we're not really sure, she could be exaggerating it. When she says that she was hit by a bus, was she really? Undeniably, oh yes, men are in pain, believe them, because they're, like Karen Asher said here, if a man comes in, he's really sick, we better believe him. If he was hit by a bus, he might have actually been hit by a bus. He must be in abject pain. And yet, even in Sierra Leone, where men and women alike have this cultural or social expectation to express pain, or lack thereof, the same, that is no better. And I would still argue that gender medicine is just as needed in Sierra Leone as it is in the US, even though it's not coming up as a topic of discussion nearly as much, and even though it's not, coming up between physicians and their patients as they interact. Still, being held to that standard is no better than what's going on in the US. And still, being held to the same standard is just in the US as we see, drug trials and medical testing is just the same. It's not acknowledging the sexual dimorphism. It's not acknowledging the inherent difference between men and women enough to treat them individually, even cultural factors and religious factors involved. And another just interesting, almost anecdotal point on Dr. Karen Asher, the female role in life in Sierra Leone, they're a predominantly Muslim culture, is for women to bear children. And for what that means for primary role of life is that if a woman has a husband and she has her children and her husband either chooses to leave her or dies, she may fully remarry. That being said, if she cannot bear children with her new husband, she will be given up into prostitution and her children from her previous marriage into slavery for the new family. So a lot of the treatment that was done over in Sierra Leone with Dr. Asher was fertility treatments, which she had no idea that she'd be walking into such a cultural difference. And she, I can quote her saying she had no choice. It wasn't something that she was necessarily thinking of doing. It doesn't come to mind as a medical necessity when you think of a life-saving surgery versus a fertility treatment. But there's very much a different cultural impact on women, which affects women's health greatly. Just a bit on how women in the obstetrics and gynecology unit experience pain. It was very common that they would see uterine ruptures during pregnancy. And again, women would get very still, very calm. You weren't really sure what was going on, but you could guess it was about 3 different things. And in the U.S., Dr. Asher did practice in the U.S. She says, if that's happening in the U.S., this woman's screaming, the birth is painful enough. But there's a very different attitude. They would just get, like I said, they would get very calm. And, even Dr. Asher said when they would do a C-section, as soon as the procedure was getting started, they would see a baby waving right at them because her uterus had already ruptured hours beforehand. They had no idea because she wasn't screaming in pain like they would in the U.S. This is a picture of the OB ward in Sierra Leone with their resources. And even Dr. Asher said there's 18 beds in the OB ward. Sometimes they'll have 23 patients. And so they're laying down mats on the floor, so the expectation with experiencing the pain like childbirth or like a C-section on a mat on the floor and having to get up to go to the bathroom or get water a day later, never something you would see in the US. You'd be bedbound for 4, 5, 6 days a week. But there's a different expectation and there's certainly different practices. My next interview was with Dr. Holly Persy. Dr. Percy works out of Cleveland. She is a chair for pediatric health and for internal medicine for Metro Health over there. And we talked a lot about some of the basic stats that, you could research online, but that she's seen firsthand affect her patients. Dr. Percy worked a lot with women with heart disease, and they found that women aren't as likely to be diagnosed with heart disease because they don't present with the same symptoms that men do. So, heart disease can often lead to cardiac failure and a myocardial infarction or a heart attack. And some of the commonly listed symptoms for a heart attack are feeling like there's an elephant sitting on your chest, there's pain in the left arm. Often a lot of people will experience sweating. But the problem is that a lot of women don't present with those symptoms. In fact, less than 2% of women that were known to have cardiac attacks or heart attacks did not present with those symptoms whatsoever. They came to the ER. A lot of them will come in feeling not right that day, not feeling like themselves, feeling like something's about to happen, just like a kind of internal guttural feeling that something's wrong that should be addressed by an emergency room. And it's funny because 90% of those patients, of those women that went to the ER and were presenting with these strange symptoms of something not really feeling right, so much so to go into the ER, were turned away. And 45% of those women that were turned away had heart attacks with no CPR involved. 85% of all women that have ever experienced a heart attack since 2014 in the US received no CPR for their heart attacks because they didn't happen in hospital, because they weren't admitted, and they didn't happen anywhere near a physician that believed that they were having a heart attack in that moment, only enough to where they presented, and at that point it was too late for either a blockage for brain damage or a fatality, unfortunately. And touching on, like I said, my key points, another one that keeps coming up is pain management. And when it comes to the US and managing women's pain, I quoted Dr. Percy as saying that women are far more likely to be treated with sedatives as opposed to NSAIDs, non-steroidal anti-inflammatory drugs, or the common Tylenol, anything like that you would take to relieve your pain. In the ER for a woman complaining of pain, they're far less likely to be given an actual pain drug, and they're far more likely to be given a sedative to control this type of hysteria or somatization or overreaction of what's going on, I'm freaking out because I'm in so much pain. Instead of treating the pain itself at the root, they're treated with sedatives to treat the emotional response that they're having, which I think really shows through in how women's pain is perceived as opposed to men. A man could be having a freak out and he could be treated for his pain, seen as, oh my gosh, he's in so much pain, he's clearly having an emotional response. And for women, the emotional response is seen as its face value. They're having just that, an emotional response. They need a sedative, just like the rest of the psych ward. It's incredible. So, for all the issues we've discussed today, what potential solutions could try to remediate this? I mean, this is a huge issue. For one, for all the testing that's been done into research and into how women metabolize drugs, the remedial research should be done on that, on how women process that. And that will help greatly with the huge difference between all the drugs that are being pulled from the FDA, including those 8 that I mentioned earlier, and everything moving forward into how women and men both metabolize vitamins, pharmaceutical drugs, pain medication, the list is endless. And another point to mention is that this really relies on physicians. This relies on physicians to do the research, to open up the medical trials, to interact with their patients with a responsibility of accepting their culture and their identity. And that physician inner work, kind of like Dr. Sabi's mention of the 5-minute rule, you're 5 minutes away from being a patient. We're 5 minutes away from being in the next person's situation. And so to take and strip away that pride that a physician has to really connect with their patient, no matter their gender identity or their intersection of identities, is really important into remediating the huge gaps that we see in female medicine. The future of the issue, I looked a bit into how gender medicine is being included into medicine now, really acknowledging that sexual dimorphism, that there is a difference. And I found a Johns Hopkins program where they look into the biological sex and differences of men and women, and that is sexual dimorphism in gender medicine at its definition. And furthermore, applying that to medicine and to medical treatments, specifically for women. I thought a good example of this was the SATI score, and this is specifically in response to immunity to the influenza, and looking at the immune system of men and women and how those are different with the sex-determined chromosomes, and how women and men fight off influenzas and how they deal with them after they're caught, how they respond to vaccines and all of that, which I deemed overly relevant in the age of COVID. And for my thesis, with more research trials testing the effects of pharmaceutical drugs and medical procedures on women, the inaccurate and inequitable data gap in medicine may be filled. Though largely dependent on the individual practice of physicians, by acknowledging the relevance of gender medicine and the impact of sexual dimorphism, women's healthcare will gradually become more accurate and applicable for treating female patients. So how does this apply to me and in my future? Where will I take gender medicine with me? I was invited by Dr. Karen Asher to go to Sierra Leone with her and actually experience some of the hospitals and the wards, including the OB ward. They've taken medical students in the past. I myself am not a medical student yet. I aspire to be. But I'm incredibly excited to take her up on that offer. Granted, it is still valid and we can figure that all out with COVID and international travel, but I'm really excited to see firsthand the gender medicine issue there, as well as everything else, and seeing how I can help out. I'm committed to a college, Case Western Reserve University in Cleveland, Ohio, right next to Dr. Holly Percy, so I'll definitely be reconnecting with her at Metro Health. And there's also a fantastic program called the Uni Health Aid within Case, and they have two programs that I'm super interested in taking a very large leadership role on. One is Women's Health, which is a very similar thesis and perspective on my gender medicine project. A lot of overlap I see there, and also a podcast project that spreads more awareness about medical procedures and medical treatments that involve women, and also acknowledging the sexual dimorphism that they speak a lot about there, which I'm super interested in. And finally, there is WISER, which is the Women in Science and Engineering Roundtable at Case Western Reserve University as well. And that's just a really great camaraderie of women. I've already connected with a few as I'm excited to enter crew in the fall, of women that are enveloped in STEAM, more from the patient or more from the physician perspective, and the women in STEAM as a field, but nevertheless really strong women that advocate for themselves and are aware of these discrepancies that we have in the world, but nevertheless willing to take it on. So thank you so much.
All right, thank you.